All right. Folks are still popping in. We get started with a couple of quick announcements. Couple of things. One, remember that for any research that you plan on completing has to be finished up by the end of this week. Okay, so Friday's the last day to get research, to finish research, all of that stuff. What happens is what we'll do is we'll go through and pull reports out of that Sona system that will register how many hours that you have and things along those lines. And then that's what will get sent out to instructors to let them know, for anybody offering research credits, how many credits people have put in. So you won't be able to be assigned credits after Friday. There will be no more opportunities. So just make sure, if you haven't yet maxed things out or got to your 6, that you're wherever you need to be. Okay, so we're here at the end of the semester, so Friday will be the last day on that. All right. Other thing too, so we'll have our quiz 7 on Wednesday. All right. This is just over this last material. Remember that quiz 7 is mandatory. You absolutely need to have a score registered for that. Well, I mean, you don't have to. It's a free country. You can do whatever you want. It'll just be bad if you don't. You'll have a 0 on your average if you don't log a score for quiz 7. So make 100% sure that you're here. You're set up. You've got a strong internet connection. All those are going to be priorities for this coming Wednesday. Okay. Now, quiz 7 isn't any different than any other quiz that we've taken. It's the same exact thing. It's just the one that I make mandatory to make sure that everybody sort of comes in and stays in, and it's attachment issues. I don't want you guys to go away. It's my opportunity to hold on to you and make sure that you're here through the end of the semester. So just make sure that you go through, have a plan for that. What I'll do is I will send out, I'll post grades like I normally do, but what I'll also do is put up a couple of scenarios for once I've gone through what your grade would be if you just had like the bare minimum 6 hours or 9 all possible extra credit. Now, if you're less than 6, your projected grade will be lower. If you're somewhere in between 6 and all possible, you'll fall somewhere in there. To let you know, to give you a sense for whether or not you want to sign up for the optional final. What we'll do on Friday, so we'll take quiz on Wednesday, and then Friday will just be our normal review session like we would normally do. We'll just use class for that. So if you think you want to go through and take the optional final, what we'll do, make sure to show up Friday during our normal class hours, and what we'll do is we'll just go through, talk about different concepts and anything that you might be not exactly 100% on. Optional final can't hurt you, okay? So no worries about if you don't score higher than your second lowest grade on quiz 1 to 6, then that's fine. Just nothing happens. It just doesn't improve your grade. But I would say that people tend to do well if they prep for this, and if you just kind of shoot from the hip, you'll probably be about where you were on the other ones. So just make sure to factor that in terms of, as we're going into finals, time to go through and prep for that if you elect to do that. Okay. I think that should be about it. Any questions? Okay. Samantha, are you out there? Do you have anything in terms of SI stuff?
Yep, we just have our last SI session tonight. It's at 6:30, just like normal, and we'll go for about an hour.
Awesome. Thank you, Samantha. Big round of applause for Samantha. Woo! You're a fan favorite. Fan favorite. We got circular clapping, all sorts of stuff going on. So yeah. So make sure for this last one, go through, sit in. Samantha will have good materials for you. Make sure that you got a good handle on the stuff here. I'll do our regular review session on Tuesday at 5 tomorrow. So I'll send out a reminder for that. So you just want to make sure, even if this last quiz 7 is going to be kind of a low impact quiz for you. What happens is sometimes people are like, oh yeah, I only need to get a 50 on quiz on quiz 7 to sort of stay where I want to be, and then they register at 47.5 or something like that. And then you're bummed because then you have to take the optional final. So just make sure to over prep for this one so that you're ready to go. And for those of you who are happy with your grade, after Wednesday's quiz, you're done. Okay. If you're good with where you're at, you are finished with Psych 1000. Okay. For those of you who want to go through and take the optional final, again, there's Friday. We'll do that. But again, we're right here at the end. So, all right. Any questions before we jump into these last couple of slides? All right. Cool. So we finished up on. Been a whole week since I've seen you guys, right? Last Monday. It's been too long. Last Monday we finished up with talking about empirically supported interventions and what these are, right? We talked about how talk therapy, psychotherapy is really difficult to evaluate for a lot of different reasons, but we do have systems where we can start to talk about how much evidence do we have for certain types of treatments for certain types of problems. Okay, and so at the top, remember we talked about well-established treatments. These are interventions that have been demonstrated to be superior to some non-specific treatment or some other sort of active thing where you're coming in and talking with people. Oftentimes this is supportive therapy, or we see that our target treatment is doing about as well in terms of improvements as some existing well-established treatment. Okay, so that's level 1. Level 2, we're not quite there at level 1, but we have probably efficacious treatments. What we're seeing is at least 2 studies showing that my target treatment is doing better than some waitlist control. Remember, waitlist is just we have people, randomize people to groups, and then we've got a group who's not receiving any type of active intervention. We're just kind of monitoring, following them up with them every week or a couple of weeks to just measure symptoms to see how people are doing. Okay, if I got 2 studies showing that my target intervention is better or sort of outperforming people who are just hanging out on their own, then we go through and we can say this is probably efficacious. What's the important feature of that waitlist control? What's that helping us rule out if we're seeing gains in my target treatment? Does anybody remember? So if I just have a treatment I'm going through and I see that people get better from the start to the end, seems like it'd be a good deal. What's my concern? Remember we talked about natural remission, right? We know that some of this distress associated with anxiety, depression kind of waxes and wanes. Sometimes it gets better, sometimes it gets worse. We know when people go through and seek treatment is oftentimes at a pretty high level. And what we don't know is for those people. So we have people come in and sort of participate in our treatment, and we see that from where they started to where they ended, they're doing better. They might not be sort of symptom free. Oftentimes they won't be, but there's at least a drop, right? What we don't know is if that person would have gotten better or would have had that same level of reduction in symptoms if they hadn't done anything at all. And so that waitlist control helps us rule out saying that our treatment is doing better than people probably would have gotten just sort of hanging out without any type of intervention. Okay, so this is our level 2 treatment. And then our level 3 treatments, these are promising interventions. We have some evidence that we've done some work with these, but not something that would rise to the level of a level 2. Again, what we have at our level 3 is our uncontrolled trials for the most part. Okay, this is, let's say Brooke's got a treatment she's developed. She's pretty excited about it, but no one's going to give Brooke the money and resources to go through a full-on RCT with this. What Brooke needs to do is go through and probably have some uncontrolled trials, having, maybe 10, 15 people come through, go through the treatment, and then just see where people are at the start, where they finish. Right now, we don't know if we're seeing improvements, whether or not those improvements would have happened on their own without Brooke's intervention. But at least we're seeing that people are finishing at a better place than when they started. So we're saying this is promising, but we need to go through and have some control conditions in there. Okay. So these are kind of ways we go through and think about the level of support for different types of interventions. We finished up on Monday talking about psychodynamic therapy. Again, this tends not to be the same thing as old school psychoanalysis, like the Freudian, like you lay on a leather couch and I hang out behind you and you just talk about things and I don't say anything. I just kind of make notes and stuff like that. More contemporary psychodynamic therapies don't look like this, but still drawing from some of the same idea concepts of unconscious conflicts, patterns based on unresolved childhood experiences, defense mechanisms, types of things, right? And so we're seeing evaluation of this resistance, again, from a psychodynamic standpoint. There are no accidents. Everything is sort of influenced by your subconscious, this countertransference, transference stuff that goes on within the context of the relationship. And then we see that we do have evidence for psychodynamic therapy as an intervention for major depressive disorder. Okay, but just the nature of this intervention, this tends to be more long-term stuff. You're going through and seeing someone maybe once a week, twice a week for an extended period of time. It's an insight-based therapy. You're just kind of going through and exploring some stuff. Okay. So psychodynamic therapy. We also can take a look at person-centered therapy. Okay, person-centered therapy. This is based on that humanistic movement. Okay, remember that the humanistic movement was originally developed as a reaction to behaviorism and psychoanalysis, sort of focusing on human strengths and potential and things along these lines. Okay, our influential figures here are going to be Rogers and Maslow. And if I'm a person-centered therapist, and this is my primary modality, my goal is to facilitate growth and achievement. Okay, I'm not so worried about diagnoses and things along those lines necessarily. Some of the stuff that we had covered in some of the previous sessions. What I'm wanting to do is you're going to come in and we're going to talk about just what's going on in your life with the goal to try and help you grow as a person, achieve, and sort of just going and sort of, again, consistent with these humanistic ideals, sort of helping you become the best person that you can be. Okay. So again, this is a little bit different than focusing on symptom level types of things. Okay. Another goal here is to help people enhance their independence and integration of self, right? So I might say, well, I kind of feel this way at this place and I kind of feel this way, I act this way at this other place. What we're trying to do is get you sort of integrated together as a whole in terms of your overall sense of self. And this is super, super important, kind of the defining feature of person-centered therapy. This is a non-directive intervention, okay? I'm not going to tell you what we're going to work on. I'm not going to have any specific goals for you. Your goals are your goals. I'm not going to tell you what you have to do or what you don't have to do. What I'm going to do is I'm going to be here and I'm going to be a supportive person, someone for you to talk to, bounce ideas off of, and just sort of kind of be a safe person that you can go through and just share whatever happens to be on your mind. And we're going to go through and talk through and work through some of that stuff. Okay. Now, if you remember back from this person-centered therapy is highly directed by Carl Rogers, right? Sort of this idea that what people need in order to succeed and be their best selves is just one person where they have a relationship marked by genuineness, empathic understanding, and unconditional acceptance and positive regard. Okay, genuineness means that I'm here. I'm not faking or putting on a face when I'm there with you. I'm genuinely interested in sort of what you're telling me. I'm there. I'm present with you. I'm being empathic, right? So you may tell me some things that sort of maybe sort of poor decisions and things like that, but I'm going to be empathic with the fact that it's impacted your life, that things are difficult for you right now, and I'm going to do my very best to practice unconditional acceptance and positive regard. That means even if you say you have an alcohol use disorder or a substance use disorder, and you used all your money to buy drugs instead of pay your rent, right? And now you're going to get evicted, right? it would be easy to judge you and say, well, that was a dumb thing to do, right? That's consequences, right? But that's not unconditional acceptance in positive regard. It's trying to see where things are coming from your perspective, and not judge you or sort of say, oh, I'll accept you if you do this, but if you don't, I won't accept you type of thing, right? Again, the idea being that sort of these characteristics are characteristics of relationships that hopefully we have somewhere in our lives, but sometimes we don't. From a humanistic perspective, it's very hard for me to grow, be the best person I can be without sort of that type of context. Okay. So if you want to see kind of an example of what humanistic therapy or a humanistic approach looks like, think about Fred Rogers. Okay, I don't know if has anybody seen Fred Rogers documentary? It's outstanding. It's absolutely outstanding. Just a pure acceptance approach, right? Sort of recognizing that sometimes things are hard, that we all need support for moving forward. Sort of this is kind of the embodiment. Fred Rogers is kind of the embodiment of a lot of these person-centered therapy ideals. Okay. In terms of level 1 treatments, what we have is supportive long-term family therapy for schizophrenia. Okay. For families that have a family member with serious mental illness, things like schizophrenia, bipolar disorder, and things along those lines. Very, very difficult and very taxing. People are doing things that we don't often understand that seem counterproductive for people getting better. But what we know in terms of schizophrenia is that we call it expressed emotion within the family. If there's a lot of fighting, yelling, judgment, sort of stress within the family, that tends to be associated with relapse of symptoms for schizophrenia. And so supportive long-term family therapy is a way to get, the serious mental illness, schizophrenia, we need medication to treat that. We can't talk therapy out of that. We can talk therapy on sort of med adherence and things like that. But the idea here for people with schizophrenia is to go through and help provide support for that family so that the family can be supportive for the person that has the serious mental illness. If we can keep sort of the heat down in that family dynamic, it's going to reduce the opportunities, the frequency and severity of relapse of schizophrenia stuff. And so we do have supportive therapy as a specific level 1 treatment for long-term family therapy for individuals with schizophrenia. Okay. Questions about person-centered therapy, anything we've got going on here? All right. So, last we're going to talk about, in terms of modalities, cognitive behavioral therapy. Okay. This is cognitive behavioral therapy based on some of those behaviors that we had talked about. Also some people sort of doing some cognitive psychology. So we've got Skinner, Bandura, Beck, Ellis, original developer of like a precursor for cognitive therapy. Something that's a little more confrontive and not something we see so much anymore. But some people from sort of the history of this. For cognitive behavioral therapy, our treatment goals to look at patterns of behavior that perpetuate distress and impairment. Okay, so let's say, Daniel, if you come in and you're struggling with depression, right? Probably what happens if you're struggling with a pretty severe episode of depression, what we might see is that you're not leaving your house and going out to do many things. You're not getting out of bed, you're not showering, you're not eating right, you're not generally engaging in things that you would normally do because you're depressed, right? But what we see is that inactivity, if you're not going out and leaving your house or doing anything, then you have no opportunities for positive experience. And if you have no opportunities for positive experience, that just makes the depression worse. And if the depression is worse, then it's even harder to go out and do things. And so we get this feed-forward cycle, right? If I'm struggling with depression, the worst place for me to be is by myself in my own head. Absolutely the worst. And so one of our major, most effective tools for depression is technique called behavioral activation, right? So Daniel, what I'm going to say, if we're working and I'm saying, okay, so what I want you to do, we'll pretend we're not dealing with pandemic COVID stuff, is I'm going to say, okay, 3 times this week, I want you to schedule an opportunity to have lunch or coffee with sort of a friend or a family member. And you might say, okay, yeah, I'll try and do that. I'm like, nope, not try to do it. This is what we'll do. You say, okay, if I feel like it. Back, nope, you're not going to feel like it because you're struggling with depression. This is the thing that you're going to go through and do as an activity, right? And so when you go out, you probably won't feel like doing it. If you did, you wouldn't be depressed, okay? But what we want you to do is go out and engage in those activities to start to break that cycle, because we know the sedentary, not going out and doing anything, perpetuates the depressive behavior or the symptoms of depression. And so what we're going to do is we're going to do some things to break up that pattern of behavior. Okay. Or let's say, Hannah, we're working on social anxiety with you. Okay. And what I might say is, okay, what I want you to do is I want you to go to the union. Again, we're assuming that this isn't in the middle of a pandemic. And what I want you to do is I want you to strike a conversation with someone that you don't know in the union. And you're like, oh boy, that's terrifying. I would prefer not to do that. I'm like, yep, that's true. Because if you were okay with that, you wouldn't have social anxiety. But what we know that perpetuates social anxiety is this avoidance, right? I'm afraid other people are going to judge me, right? So I avoid other people. And so whenever I get an opportunity to see that probably if I go through and ask someone for help or strike up a conversation, they're not going to tell me I'm stupid or dumb or laugh in my face or point at me and think I'm a freak. It'll probably be just fine, right? And so what we see is what we'll do is some exposure exercises to start to break up that avoidance behavior that perpetuates the social anxiety. Okay, so again, what we're doing is sort of taking a look at these difficulties and trying to understand what behaviors are going through and perpetuating some of the distress and impairment. Okay, so that's kind of the behavioral part. The cognitive piece of things is going to be identifying and challenging some unproductive patterns of thinking that people may have. Okay. And thinking about this when we're talking about emotion, right? Those appraisal theories of emotion, where the idea is like something happens in the universe, I develop a sort of some appraisal or assessment of that situation, which then results in some types of emotion. That's the cognitive aspect of cognitive behavioral therapy. So, Daniel, if you're struggling with depression, Daniel's not struggling with depression, he happens to be on my screen right now. But Daniel, if you were struggling with depression, probably a lot of the type of the thoughts you would have is, things will never get better for me. I always fail. Nothing goes right. I'm pretty useless and a burden on everybody around me, right? So what we might start to do is go and explore some of those ideas or some of those thoughts and say, boy, I don't know. It seems like you're taking care of your family. You're holding down a job. You're doing a lot of things. Doesn't seem like a burden, right? So what about sort of your dynamic would suggest that you're a burden, right? Or what types of things might suggest across your life that you're a failure? And if we actually start exploring that, it looks like these are some unhelpful ways of thinking that we start to cherry pick all the negative, disregard the positive, and sort of start looking at some of that stuff. And same thing, Hannah, if you're struggling from social anxiety, right? You say, well, people, if I went and introduced myself to someone, they would laugh at me and I would be humiliated. Like, okay, well, and have you ever gone through and introduced yourself to somebody and they laughed at you and pointed and humiliated you? Well, no, that's never happened. Like, okay, well, if it's never happened, how old are you? 18, 19, 20? Like, it's a pretty good chunk of time. So that seems like low risk, right? Or maybe that did happen. What would be the worst thing that would happen in that situation? It seems like you found someone who's kind of a jerk, right? What they think about you doesn't actually matter, right? So starting to go through and work with some of those cognitions that keep maintaining some of the stress, okay? And then finally, trying to think about adaptive coping skills to manage the stress, okay? There are lots of things that we can do that help us manage negative emotions and feelings, and other things that also work in the short term but are not so great over the long term, right? Avoidance is a great way to manage my distress, right? If I'm nervous about doing something or going somewhere, if I just don't do it, then I'm good, right? If I'm scared to go to Walmart because I might have a panic attack and I go down to Walmart and start feeling anxious, easiest way to drop that out is just a split and get out of there, right? But what we see is that avoidance goes through and perpetuates some of the symptoms, right? So what we would do is try and talk about different relaxation techniques or breathing techniques or sort of other types of things to help manage emotion other than drugs and alcohol or things along those lines, right? So helping people develop positive ways of going through and managing stress. So techniques, psychoeducation, this is just giving people information about certain types of conditions, right? Kate, if you come to me and you're struggling with symptoms of OCD, right? Probably what we would first do is talk about what OCD is, what we know about it, how we understand how it impacts functioning, the relation between obsessions and compulsions, and sort of we give you a bunch of information so that you are going to be an expert in OCD, the stuff that makes it tick. Okay, we got relaxation techniques, behavioral activation. We talked about that. Exposure treatments. So again, this is exposure is a good thing. I think an easier thing to sell in Wyoming for all of you if you're from Wyoming or to more rural areas. Any of you ride horses? Anybody horseback ride? Okay, you get bucked off a horse. What do you do first thing? Someone knows. You get back on, right? What happens if you don't get back on? And you're scared. Then you let the horse win. And then you never get back on because you're too scared you get bucked off, right? Exposure is basically the same thing, right? I'm terrified of driving, right? I'm terribly, terribly anxious that I'm going to get in an accident or I'm going to run somebody over or someone's going to be killed or something like that, right? It's like, well, recognizing that there are always risks with driving, so that your fears may be at a greater level than what's warranted. Not driving is causing you impairment, so what we're going to do is we're going to start small and work our way up, right? So what I'm going to do, Jacob, I'm going to have you first maybe just drive around your block, right? Until you do that, and I'm going to have you sit there and be in that until that anxiety that's getting really high starts to come down, right? We're not wired to be perpetually in an intense state of constant fear. If I hang out with that long enough, it'll start to come down, right? So maybe we do that until you're comfortable driving around the block, and then we increasingly start to expand your radius into things that start to make you more and more anxious, right? Maybe it's distance, maybe it's the type of roads, maybe it's weather conditions, things along those lines. And what we see is that anxiety starts to decrease the more you're out there engaging in these exposure exercises. It's tricky. We want to do it carefully so that you don't think that I'm some sort of sadist and just like to sort of make you anxious. But if we're not sort of poking that and sort of getting you sort of generating some of that anxiety, we're probably not going to make much progress in getting you over that driving related fear. Okay? So these are our exposure techniques. Cognitive restructuring. This is working with some of those negative belief systems that sort of maintain distress and impairment. So Jacob, your idea is like, if I drive, I'll get in an accident and die. It's like, okay. How likely is that? We're like, I don't know, at least 50%. So you're saying like half the time when people go out and drive that they're killed in car accidents. Does that make sense? No, right? And so we start to go through and sort of look at some of those beliefs that feel very real, but upon examination, we can start to see how their distortions are maybe not helpful, things along those lines. Okay. And then different skills training, right? Teaching people how to use different coping strategies, how to go through and navigate things successfully. Assertiveness training is a big thing that's often used, right? So if have social anxiety and I have a hard time saying no to people, and what I end up being is a doormat, basically. People take advantage of me and ask me to do unreasonable things, but I'm afraid of evaluation if I say no, and so I don't, right? And so maybe we work on ways to be assertive, or on the opposite end, maybe I'm just a tinderbox and I can't have a disagreement without blowing my top, right? So what we might do is use those same assertiveness techniques to talk about how to tell people appropriately, sort of, no, I would prefer not to do this without sort of burning bridges and things like that. Okay. So this is kind of sort of some of the goals of our cognitive behavioral therapy interventions. Questions on this? I see one in the chat. Do you ever have to change what type of therapy you plan to use partway through the treatment? Sometimes. Sometimes. That's actually a complicated question for a lot of different reasons. But if we've got a good sort of understanding of some a person's difficulties and what's causing some of those, or at least contributing to those, we'll want to go through and make sure that we give things enough time to go through and move forward, right? Like, there's no magic bullet, right? If you come in with severe depression, I don't have a quick fix for that. No one does. If someone tells you they do, they're lying to you, and watch out for that. It's generally something that's going to take some time to go through, and it's going to be time and effort on your part, right? And for some people, particularly if I'm doing okay and I'm making it by, sometimes the time and effort related to treatment isn't sort of something that I'm sort of willing to put in right now, right? So want to give someone sort of enough time to go through and see if whatever we're doing is going to make an impact, but also not beating our head against the wall, doing the same thing over and over again. If we've been working on this for months and it's clearly not working, sort of want to think about, okay, so is there, what's going on to go through and change things up a little bit. So any questions about goals of CBT, what we're trying to do with this?
Could this type of therapy be used in certain criminal settings where a prisoner has some sort of disorder that can be fixed or at least partially fixed by CBT?
Yeah. And there's a lot of, and sort of, okay, that's an interesting population, right? Depending on what type of thing that person has led to incarceration. There's obviously substance use stuff that contributes. Kind of the big one people would think about is antisocial behavior, which we tend to think of as a personality disorder, kind of a long-standing thing. And so some work to try and do from a CBT type of approach to try and help with that. One of the hard things, also interventions for sex offenders and things along those lines, right? Tricky thing there is if, I'm walking around in the big wide world and I'm struggling with something, right? Ultimately, it's my choice as an adult to come in for treatment. I'm like, boy, this is getting bad. It's kind of getting out of hand. I'm going to go try and get some help. Dynamic changes if I'm an incarcerated person or a child, and someone who has control over me says, you will go through and do this. Then things start to get a little bit trickier. There got to be more work on the front end to try and get. It's if someone does not want to change, it's easy to just not do anything that I ask you to do, or sort of consider the things I'm asking you to consider, and then sort of we're kind of at a stalemate, right? But yeah, these types of interventions are used within criminal settings and things like that for rehabilitation and stuff like that. Yeah. Any other questions?
I have kind of like an add-on question.
Yeah.
So how do you get some of these people, like very depressed people, to go to therapy? Because that's the first step, right?
Yeah.
A lot of the depressed, secluded people don't want treatment. Right?
Yeah. Well, I would say, Vance, I don't know if I would say not wanting treatment. There's a lot of there's actually a ton of barriers to getting people. One, finding someone who's doing good, reasonable treatment that's not some magical nonsense intervention. Other thing too is, can I pay for that? Do I have insurance? Can I go through and afford? Other thing too is, am I going to get on a wait list? So how long do I have to go through and get in and stuff? And so there's a lot of like logistical, like practical barriers going on. But particularly with depression, sort of the nature of depression is if I don't have the energy to do anything at all, I don't have the energy to get out of bed and brush my teeth, do my laundry, much less travel from point A to point B to get in and seek some treatment. And so this is oftentimes something that happens over a long period of time, and sometimes it's when symptoms have gotten bad enough so that either other people outside in sort of my existence are sort of encouraging me to go in and seek treatment, right? Same thing with anxiety, right? Do a lot of work with anxiety. It's a lot of what I study. People will build their lives around avoidance stuff, right? Back, oh, no, it's fine that I only go and do my shopping at 2 a.m. is because it's easier to do it that way. No one's around. It's actually pretty awesome. Everybody should do their shopping at 2 a.m. Like, well, if you just wanted to shop at 2 a.m. just because you felt like it, that would be one thing. If you have to shop and can only shop at 2 a.m. because otherwise you can't go into the store without having a panic attack, then that's a different thing, right? And so the justification people would sort of shape my life, and usually it's at a point where sort of family members, friends are saying, like, you need to go get some help. That will often push people into treatment. Also stigma, right? Think about, hey, I don't want to be, I'm not a nutcase, or sort of therapies and head shrinkers are for weirdos or people who are defective. We talked about how common mental health stuff is across the entire population, right? It's so there's a number of reasons that can be why people will be hesitant to go into treatment, and that's hard to address, sort of if you're the clinician. But once you get people in there, again, a lot of the stuff is using some of those humanistic techniques. So just being there, being present. Cognitive behavioral therapy, we have a bunch of techniques and things like that that target specific symptoms. But on top of that, you need to sort of be a reasonable human, someone that someone's comfortable with, and things along those lines. But if you're a family member or friend of someone who's struggling with depression, it can be it's hard, right? You say, hey, you need to go get treatment. That person might not be ready to go and get treatment, might not have the capacity to go in. And so, yeah, it starts to get really tricky, and it starts to become easy to start blaming that person. Well, if this was so bad, why don't you go get some help for it, right? Which starts to get into a tricky dynamic with stuff.
Oh, okay.
Yeah. Any other questions? All right. So, level 1 treatments for cognitive behavioral therapy. There's a lot of them, okay? For adults, we got panic disorder, all different types of phobias, generalized anxiety disorder, OCD, PCD, social phobia, depression, anorexia, binge eating, sort of eating pathologies, chronic pain, headache, smoking, sort of marital problems, sexual dysfunctions, borderline personality disorder, schizophrenia. These are, again, serious mental illness with schizophrenia, and some bipolar disorder, right, where we need to have people on medications. These are medications that have some pretty nasty side effects sometimes. They're better than they used to be, but they're still sort of not great. And so getting people to stay on medications and sort of treatment adherence is important. Providing support for families, different types of token economies, social learning types of things, rewarding people for positive behaviors and not reinforcing behaviors that are problematic. In kids, we have CBTs for ADHD, cognitive disorder, encopresis, enuresis, phobias, autism spectrum stuff. So lots and lots and lots of treatments, level 1 treatments. And question pop up in the chat. To be clear, are level 1 treatments the very best treatments? Yes, level 1 treatments are the very best treatments. And so what we see is lots and lots and lots of interventions, cognitive behavioral interventions that have been tested and found to be effective for all sorts of different types of specific conditions. Okay. Now, if I'm someone if you take a look at, and so this isn't 100% up to date, but if we got sort of looking at this, right, and then we get to that, it's a big difference, right? And if I'm not someone who's a cognitive behavioral approach to treatment is sort of looking at a specific problem, looking at sort of the types of things that sort of we can study and sort of go through and perpetuate that, then we can go through and say, okay, these are the outcomes if this is the behavior that's perpetuating the difficulty. Then we're going to go through and try and intervene there and sort of break up these cycles, right? Now, if I'm maybe a psychodynamic person, I'm like, well, that's the things that I'm doing are sort of process things that aren't easily quantified into numbers and research and things like that, which is fine, I guess. But at the end of the day, if you can't show me evidence that this is an effective thing, then I'm not going to be I'm going to be less convinced than if I can say, hey, these are people who came in with this specific thing. Here's where they started. Here's where they ended. This is the types of activities that we went through with this package to go through and do. Some people get upset about sort of this piece of things, particularly if they're not taking an approach from a cognitive behavioral standpoint. But I mean, I don't know. It's fine. I mean, there's no law against sort of doing whatever type of therapy you want to do. But just the state of the literature suggests sort of lots and lots and lots of support for these CBT types of interventions, and less sort of concrete evidence for a lot of the other things that people are out there doing. Question, true that people with bipolar disorder have trouble seeking help in therapy? Yeah, a lot of times, right? Particularly if I'm in the throes of a manic episode, I'm on top of the world, and I'm out to save the universe, and I'm getting messages from the president and sort of other high-level people sort of in other areas, and I'm sort of on a mission to do X, Y, and Z. I'm not open to hearing that those are delusions, that I need to get on medication to bring myself down because I'm feeling on top of the world. And so it can be hard to get people sort of into treatment on medication management with a lot of that stuff. So, all right. Questions about sort of level 1 treatments? All right. This is an incredibly important slide. The American Psychological Association has resources available for, they kind of summarize some treatment evidence for certain types of treatments and certain types of disorders. If you go here, all sorts of information. This can be very, very helpful. If you go out into the world, it can kind of be a bit of a Wild West show in the types of things that people do, right? And it starts to become very important for people in the community to be informed consumers of mental health resources. And so this is a really, really nice website where you can go. If you or anybody else you know is struggling with some type of condition, you can look at sort of things by different diagnoses, things by different treatments, and go through and see what types of interventions have differing levels of support for different things. And then that can help sort of direct, if you're looking for a provider, sort of what types of things to look for and all of that. Okay, so bookmark this site somewhere in your brain or your records or something like that. Incredibly helpful and useful resource. Okay. All right. What about stuff that doesn't work? Okay. I said it was a Wild West show out there. The stuff that people will come up with and sort of for mental health treatments we're not super regulated, right? I mean, there's a lot of things, and there's a lot of freedom to go through and practice the types of things that you want to practice, right? But the problem is that we often don't think about psychotherapy as having negative side effects, but it certainly does, depending on what types of things we want to do, right? If I put together a medication, I might go, hey, here, go ahead and take this pill. Lots and lots of stuff that have to go through to make sure that those side effects aren't toxic, things along those lines. No one's sort of doing the same thing for interventions. And so what you can do is you can have people who go through, and I will give them a benefit of the doubt, likely feeling that what they're doing is going to be effective, but at best, likely not effective. At worst, one being actively harmful, and sort of maybe less worse, taking up people's time, energy, and resources when they could be directed to something that could be helpful, right? If I got going out and I sort of got some crackpot treatment for some medical thing that even if it's not hurting me, it's keeping me, I'm sort of involved in that instead of getting actual real treatment that could be helpful. And so some examples here, recovered memory therapy, right? Anytime that you've gone in and recovered a memory or something along those lines, should be very, very suspect of that for all the reasons that we talked about in terms of memory construction, right? Entities therapy, this is, you've got spirits in you that are causing sort of something that is creating distress, so there's a cultural aspect to this. This isn't sort of a culturally sort of thing. This is sort of your anxiety and depression is sort of based on spirits that have sort of taken on your, that have entered you. Evil entities there, these are not just spirits, these are bad entities that have gone through and taken up. So not a lot of evidence for sort of that. Rebirthing therapy, okay, this is a sort of form, this is a serious one. This is sort of attachment therapies, right? This idea that my difficulties with my relationships are based on the fact that I didn't have a good attachment to my mother when I was born. And so what I'm going to do, Hannah, is I'm going to go through and I'm going to have you come to my office and I'm going to sit on you and smother you with pillows and force you to come and struggle out so that you can be reborn and develop attachments. Okay? And I don't know how big you are. I'm 6'4" and probably like close to 270 pounds. What happens if I take a bunch of pillows and sit on you and force you to come out?
I'm probably gonna like suffocate.
Yeah, I'm going to kill you and you're going to suffocate, particularly if you're 12, right? And so what happens is, one, the whole idea is nonsensical. But two, if I'm talking with someone who's in a bad spot with their kids and they've tried other things and not a lot of success, it could start to sound compelling, right? Because it's mystical psychology stuff, right? But what can happen is I can accidentally kill people doing this stuff, right? And that stuff happened. Now the attachment people say, oh, we don't do that anymore. Like, oh, you don't kill people anymore with your weirdo therapy. Oh, thanks. That's like, not willing to give people a whole lot of credit for we don't kill people anymore stuff. So again, one of those examples of how things can start to go backwards, right? Thought field therapy, sort of going through tapping sort of things to go through and sort of, I'm going to tap on sort of parts of your body to sort of rewire your brain. Facilitated communication. This is a tricky one. For a while, I think in like the 90s, this idea of people with severe autism spectrum disorder, developmental disabilities, having someone physically hold their finger and type things out, which again sort of got people really excited, say, oh, this is someone who's just trapped inside their body and they can't, if I go through and facilitate the communication there, what it looks like is if you're only telling whatever message to the person, the client, and not the people who's moving their finger around, all of a sudden it doesn't work anymore, which suggests that sort of those person moving the finger around is maybe not trying to be deceitful, but sort of there's stuff going on there. Sensory integration therapy, Erlen lenses. This is going to fix your autism by giving you glasses that sort of turn things around. Dolphin assisted therapy. Like who? Sure, right? Like who? Yeah, no, I'm going to pass on swimming with dolphins. No, that sounds awesome, right? And if I'm depressed, right? If Daniel's depressed, maybe swimming with dolphins. Right after swimming with dolphins, Daniel, how do you feel? I'm like, yeah, that was pretty good. Is that gonna? Yeah, right. You're down with it. Does that help your depression 2-3 weeks out? Probably not, right? It's also probably wicked expensive, and now all of a sudden you've spent a bunch of money swimming with dolphins instead of sort of getting something that could be effective over long term. Scared straight, we love this, right? Like I'm going to take you into prison and have inmates get in your face and scream at you, right? It's not effective. Primal scream therapy, this is you screaming into the void to help get out your stuff. That's not effective. It'll damage your vocal cords. Conduct disorder boot camp. People are super into these, right? We're going to send these kids off to some military style boot camp and we're going to sort of get them worked out. It's not effective. It doesn't help. It also puts people in a lot of position to start to abuse people and a lot of bad stuff. It's not good. Dare, that's not effective. We've known that forever, and we still do it. Like, don't use drugs. Cool. Remember that when we're adolescents, our frontal lobes aren't like I don't have the brakes. I don't have the machine. So if my friends and a bunch of people I like are like, hey, smoke this, I'm like, okay, right? Because I can't not do those things. Well, I can. It's just my machinery to not do that is severely impaired. Anything having to do with multiple personalities, herbal medicines, it's fine, right? If that's part of your culture and sort of part of your belief system, and you're sort of like into sort of natural medicines and things like that, that's cool, and sort of do that, but it's not something that's effective, shown to be effective for treating anything specific. Same thing with spiritual healing. Conversion therapy is terrible. The APA has said like that's not a thing to do. That's again another thing that's actively harmful. You see higher levels of depression and suicide in people who have tried to change sexual orientation through some of these conversion therapies. Not recommended. And so there's and this isn't even close to all the stuff that people are doing. Okay. The thing to remember is if you're going out and you or anybody you know is seeking mental health treatment, you are 100% within your right to ask whoever's providing that treatment to explain to you what it is, why it works, what it's going to happen. If people start getting cagey with you and upset about it, you need to split, right? No one should have you doing things that you don't feel comfortable with or seem strange and absurd or cost an exorbitant amount of money without some evidence and so some justification, right? So definitely want to be good consumers of things when you're going out and receiving treatment. So again, summary, evaluating psychological interventions is hard. It's complicated, but we can do it, right? It's not impossible. We do have evidence of specific treatments being effective for specific types of problems based on sort of our research and looking with some of this stuff. We've got different sort of main types of modalities that are looking at differences in how they're going through and approaching things. But, you know, there's a lot of common stuff across these different, we might talk about it or just call it different things, but there's only so many new things out there in the universe. We're kind of all using a lot of the same processes, just some interventions are using this a little bit more efficiently than others. And then the idea is here, just be an informed consumer. Never be afraid to ask questions, and always be cautious or skeptical if someone is offering you silver bullet sort of magical outcomes that are going to fix things immediately with 100% certainty. That's just not how the world of mental health works. So just sort of being aware of that stuff. Okay, comprehension check here, but that does it. This is the end. This is the last lecture that we'll go through, cover materials. This gets us all out of the way with stuff. Any questions? Feeling okay? Comfortable? All right. Well, thank you all for allowing me to stand on my soapbox here at the end of the semester. For a lot of you, this is probably going to be the last time I go through and I see you, just because you're going to be A-okay and good to go, which is awesome. I'll go through once we get quiz 7 out. We'll get things scored, give approximation on grades. That should give you an idea of where you're at. But if you have questions or sort of wondering whether or not it makes sense to take the optional final or not, just email me. I'll help you out and get things figured out. Anything before I let you go? Before I let you all go? Okay, cool. Well, thanks for hanging in. It's been a weird semester, but I've really enjoyed being able to do live lectures with you all. It makes it sort of much more interesting than me just talking to myself in my office. Again, make sure that you go through prep for quiz 7. Make sure that you're there and you have a strong internet connection on Wednesday, 11 to 12. Very, very important. But otherwise, if I don't see you again, enjoy your break. Be safe. Be healthy. And let me know if anything comes up. All right. We'll see everybody. Thanks for a great semester.
Thank you, Professor.